He's very smart, but he just, so we're going to be talking more about the chemical reactions involved in the reagent strip. So we learned there are two parts of urinalysis. You're going to do the chemical portion and then the microscopic portion. We're going to be talking about the chemical portion. So these are all the tests in the chem strip. This is what one of the, I don't want to say answer keys, but when you have a like bottle of, we use multi-sticks 10, it's going to have this chart on the side. And this is what if you're doing a manual chem dipstick, this is what you're going to use. So the glucose, bilirubin, you read them in 30 seconds, ketone 40 seconds, specific gravity 45 seconds. The rest are 60 seconds, and then the leukocytes are 2 minutes. You allow the urine to come to room temp, mix gently, dip the strip so all the pads are moistened and remove it immediately. Withdraw it in a continuous motion while removing excess urine by dragging it across the edge. You read the pad color on the chart at specific time intervals. Just like that. It's quick, easy, inexpensive, stable, and requires a small amount. However, it's subjective. I've had times where I've had to bring another tech over. Like, is this a 1+? Is it a week plus? Do you see a color change? And it does take more time than just throwing it on an analyzer and walking away. It's important to store the reagent strips in their bottle with the lid closed so they don't absorb any moisture from the atmosphere. Do not expose them to sunlight. That could affect the bilirubin pad. Don't expose to heat or cold. That could affect the enzymatic reactions on some of the pads. Volatile substances and moisture. Only remove the number of strips you need for immediate testing. Do not use discolored pads. Do not use expired reagent strips. And only test urine which is brought to room temperature. So the top is the example of a good strip, and the bottom is the example of a strip you would not want to use because one of the pads is already discolored, and I would discard this. I would go through the bottle, and if I found a few more that were like that, discard the whole bottle. I would consider it contaminated. And we're going to talk about urine glucose. Normally contained in glomerular ultrafiltrate, but then reabsorbed in the proximal tubule. Not present in urine unless threshold levels in your plasma or serum exceed 160 to 180 milligrams per deciliter. A spillover into the urine is indicative of kidneys. It can also occur in burns. I've seen that. We have a burn ward here. A lot of the patients, when they first come in, when they're acutely damaged and their body's still in that first trauma response, they can have transient glucose in their urine. It's also present in kidney failure, central nervous system disorders, and myocardial infarction. So the renal threshold for keeping it contained in your blood is 160 to 180 milligrams. Glycosuria, which is glucose in your urine, is dependent on blood glucose levels, your glomerular filtration rate, and tubular reabsorption, seen in diabetes and congenital forms of glycosuria. I do not know how in depth they want you to know these reactions. He has put them on here for each pad. This is probably a question I would ask your professors. I'm not going to go too in depth with them. I'm just going to let you know that the glucose, it is a two-part reaction. It uses glucose oxidase and peroxidase, and the bottom sensitivity is 0.1% glucose in your urine. Some things that can cause a false positive are oxidizing agents, such as peroxide or hypochlorite. So bleach can cause a false positive for glucose. With some automated methods, elevated urobilinogen can also cause a false positive. False negatives are seen in cold urine, because the enzymatic reaction is slowed down. Urine with a high specific gravity, it can affect your glucose oxidation. A highly alkaline urine, high ketone levels, and vitamin C in high doses, because that will compete with the peroxidase in reaction number 2. Urine with reducing substance. So reducing substances can be found in urine. They are oxidized sugar with a free aldehyde or ketone group. So some of them that are occasionally found in urines are fructose, galactose, lactose, and maltose, not sucrose, which is table sugar. Reducing sugar is any sugar that can act as a reducing agent, which means it donates an electron. Dextrins, homogentistic acid, and glucuronidates can cause a false positive. They will give a positive copper reduction test. And the copper reduction test is the way we determine if the substance is truly glucose or if it's one of the reducing substances. So a lot of times infants will have reducing sugars in their urine from inborn errors of metabolism. Like sometimes the babies can't process fructose or galactose, and that'll spill over into their urine. So it can show up as glucose, but it's not really. It's one of these reducing substances. So we have a separate test that helps us determine, is this glucose or is this one of the other reducing sugars? And we do that with the Kiehl test. So this helps us determine if there's a reducing substance in the urine. It is this little round tablet that has copper embedded in it. You put a few drops of urine, like a drop of water, and then put the copper tablet in, and it'll bubble. It'll heat up and bubble. If there's no reducing sugar present, it'll stay blue, and then it changes gradually to an orange the more reducing substance is present. If it's bright orange, that means there's 2% reducing substance present. It can detect as low as 0.25% in your urine. So it's otherwise known as the Benedict's test. We call it the Kiehl test because that's the brand we use here. So it screens for reducing substances. Glucose can give it a positive result, but it's not specific for glucose. It's specific for any of those reducing sugars that we talked about, not sucrose though. The reaction is copper sulfate with reducing substance in urine to convert the cupric sulfate to cuprous oxide to cause a color change. Blue is negative, orange is 5+. It is exothermic, it will heat up, and you need to watch it the entire time. A large amount of reducing substances can make it go from orange back to blue. So it's not something that you can just plop in, walk away, come back, and look at the color change. Some things that'll give it a false positive are vitamin C, which is also a reducing substance. So that'll give a false positive if the person is getting like large amounts of supplemental vitamin C. Nalidixic acid, that's an antibiotic. Cephalosporins, which are immunosuppressant. Urbanicid, which treats gout. And any urinary preservatives like formalin and formaldehyde in large quantities. What's the significance of reducing sugars? It's routinely performed on urine from children children less than 2 years old. And we use it to detect metabolic defects. So here's a little chart he put in. Your dipstick glucose is positive and your Kiehl test is positive. That means glucose or glucose and something else are present. So if your glucose is negative and your clinic test is positive, that means a reducing substance or reducing sugar that is not glucose is positive. If your glucose is positive and clinic test is negative, that means you have a small quantity of glucose. We're going to talk about the urine bilirubin. Urine bilirubin is formed by hemoglobin degradation in the reticuloendothelial system. And the reticuloendothelial system are phagocytic cells that remove dead cells and foreign substances from the body. Bili is bound to albumin and transported through the blood into the liver. Free unconjugated bili is insoluble in water and cannot be filtered through the glomerulus. So conjugated bili is conjugated with glucuronic acid. Now it is water soluble and it's excreted by the liver through the bile duct and into the duodenum. So what we're detecting in urine is small amounts of conjugated bili regurgitating back from the bile duct into the blood system. Conjugated bili is filtered through the glomerulus and excreted in the urine whenever the plasma level is increased because it's not bound to protein. And normally there are no detectable amounts in the urine. It's usually present in urine when the bile flow to the colon is obstructed. There's liver damage, we have hepatitis or cholestasis. Because it's not bound to protein, it's easily filtered through the glomerulus and excreted in the urine whenever the plasma level is increased. And it is the diazo reaction, so it's bilirubin plus a diazide is conjugated to azobilirubin. And our confirmatory test is something called an ICTO test. I think we talk about that later. The false positives can be reading errors if you let it go too long and you read it after the prescribed time. Atypical color reactions are produced by indicans. That's a precursor to indigo dye. I don't know why you would ever have that in your urine. Metabolites of etidolac, which is the generic for Lodine. Lodine treats rheumatoid arthritis. There's also chlorpromazine, which is the generic for Thorazine. That's an antipsychotic. And then metabolites of that azo I was talking about, phenazopyridine, that can also cause your bilirubin pad to be false positive because it'll just make it look orange. So false negatives. Large amounts of vitamin C, ascorbic acid, will decrease the sensitivity and give you a false negative. High levels of nitrite, which are produced by bacteria, will also give a false negative, and exposure to light and room temperature. So there are two types of confirmatory tests. There's the ICTO test and the ICTERO check. You can also check with the foam test because bilirubin alters the surface tension of urine and foam develops. So if there's foam present, that can all either indicate protein or it can indicate bili. So one of our confirmatory tests is the ICTO test. The reaction is the same as the dipstick. And he gave you the ingredients right there and the reaction. So down there, you put the little pad on like a white piece of paper or a white gauze. You put 2 drops of the patient's urine on it. And if there is bilirubin present, you'll get a purple reaction. The ICTO test is more sensitive than the dipstick. The lower limit is 0.05 milligrams per deciliter. Okay, next is urine ketones. So this is the normal formation. They result from the breakdown of fatty acids. They're produced in the mitochondria of liver cells, and one of the intermediate products in fatty acid breakdown is acetyl coenzyme A. They're produced in the citric acid cycle. I have some notes here. Fat stored in the tissues are released as free fatty acids when insulin levels are low. These fatty acids will combine with coenzyme A to form acetyl coenzyme A chains. And the chains are then broken down into individual units by beta oxidation. Then they enter the Krebs cycle. They combine with oxaloacetate to form citrate. However, during starvation, type 1, like type 1 diabetes, low carb diet, stuff like that, the oxaloacetate is diverted for gluconeogenesis. With the oxaloacetate unavailable, the acetyl enzyme CoA is diverted to the formation of 3 types of ketones: acetoacetate, beta hydroxybutyrate, and acetone. I think here we just went over that. Oxaloacetate is diverted into the gluconeogenic pathway when carbs are absent. Carbs are absent. When no oxaloacetate is available for condensation with acetyl-CoA, then coenzyme A cannot enter the Krebs cycle, and it's diverted to the formation of ketone bodies. And I think he's just giving you the chemical reaction right there. And these are the 3 types of ketone bodies. They're usually very low in your body. 20% of them are acetic acid, 78% is beta hydroxybutyric acid, 2% is acetone. Acetone is lost very quickly in the air at room temperature. So if a doctor wants to test either a blood test or a urine test for acetone, it has to be tested very quickly after the sample's given. And you can't leave the container open long because it just evaporates. What's the significance of urine ketones? They can be present in basically any state where the person's not getting adequate nutrition. Diabetes mellitus, diarrhea, exposure to extreme cold, fasting, fever, low carb diets, malnutrition, strenuous exercise, and vomiting. This is the reaction. It's the sodium nitroprusside reaction. I think they just want you to know the main chemical in the reaction. You won't have to like write out the entire reaction. So for this, you just need to know it's the sodium nitroprusside reaction. And we also have a confirmatory test for this. It's the acid test. I think we go over that later. So urine ketone false positives can be caused by highly pigmented urines, a high specific gravity and a low pH, levodopa metabolites. And I believe levodopa is a drug used to treat Parkinson's. Sulfonyl groups, phenylketones, and phenylketones are produced in phenylketonuria. Phthalate compounds, and any positive and questionable results you can confirm with that acid test. False negatives, prolonged storage because ketones quickly evaporate. Ideally, you want to test it within 2 hours. Most commercial tests only measure acetoacetate. The beta hydroxybutyrate may be missed if you are just using a dipstick. So the acid test, it still uses sodium nitroprusside. It's 10 times more sensitive to diacetic acid, which is diacetic acid is the acetoacetic acid, than acetone. However, it also does not react with beta hydroxybutyric acid. You can use urine or blood on this test. Urine specific gravity. We went through this in the previous slide. Normal is 1.008 to 1.030. Dilute, it's from fluid intake or diabetes insipidus. Concentrated from dehydration or diabetes. I have seen above 1.035. I know I've said the kiddies can't do that. If you have radiographic dyes, if you've had like a urogram, CT scan, and they've given you a radiographic dye, you can get above 1.035. That is the only case where you will get above 1.035 in a specific gravity in your urine. I've seen it as high as like 1.040. And that's the only case that'll happen. That's the only time that'll happen. So how does the urine specific gravity work? The dipstick measures ionic solutes, and it reflects the concentrating and secreting ability of the kidneys. It uses polyelectrolytes and an indicator. Bromthiamyl blue turns to yellow based on the pKa change. Oh, how's that about that? Okay. Now we're going to the blood. Okay. Urine occult blood. It is H2O2, which I believe is peroxide, plus a chromogen. Turns into oxidized chromogen plus peroxide. The sensitivity is 5 red blood cells, or as low as 0.015 milligrams per deciliter of hemoglobin. So what can cause a positive blood reaction? If it's intact red blood cells, that can be from your glomerulus, your renal tubules, your ureters, or your bladder. Now, hemoglobinuria is free hemoglobin. That can be from glomerular filtrate or intravascular hemolysis. Myoglobinuria, that's free myoglobin from muscle damage. And we see that a lot in burn patients or someone with a crush injury or another type of severe injury like that. They can occur individually or they can occur together. They're normally negative. And when you do see them, you have to correlate them with the patient's, the other results and with the patient's diagnosis. Are they present under the microscope? Do you see red cell casts? And if there are numerous squamous epithelial cells and you see like some clots, it always could be menstruation. It doesn't necessarily mean there's a pathological issue happening with the patient. False positives, oxidizing contaminants. So if there's bleach in there, bacterial peroxides, some bacteria do produce peroxides, and if you have extremely high concentration of that, they can cause a false positive. Menstrual blood, and betadine, which is used to, that's like that iodine that they use to like clean you for surgery. So if they cath you and they use that to clean the cath and they get some of that in there, it can cause a false positive. False negative, if you don't mix it correctly and you don't get the red blood cells up there, if they all settle at the bottom, formalin can cause a false negative. High concentrations of vitamin C. Know that, they ask about that. High concentrations of vitamin C will cause a false negative in your blood. Capitin, which is, it treats high blood pressure. That's a drug that treats high blood pressure. A high specific gravity will cause a false negative. Positive nitrites in large concentrations can cause false negative, and protein. So hematuria is intact red blood cells. If they are lysed in the urine, you can see ghost cells under the microscope in the sediment. That's usually in a highly alkaline urine or with low specific gravity. The urine could appear grossly normal. Hematuria can indicate renal diseases affecting the glomerular system, tubular, interstitial, vascular. It's also present in patients with kidney stones, bladder cancer, and urinary tract infections. So if you don't have red blood cells and you have lysed red blood cells, then you have hemoglobinuria. That can be from intravascular hemolysis. So that's where your red blood cells are being lysed within your circulatory system. We've seen that in incompatible blood transfusions, where they have a really bad transfusion reaction and they just start lysing all the donor cells. and then the patient will start urinating. They don't urinate intact red blood cells, but they urinate the hemoglobin from inside the red cells. Hemolytic anemia is another one that we see that with. Burns, cold autoimmune anemia, that is where your body forms antibodies to your own red cells and attacks it. Electric shock and something called paroxysmal nocturnal hemoglobinuria. I think we talked about that later. And confirmatory tests are the hematest and benzodine test. The hematest it's another tablet test to test for occult blood and stool, but it can also be used for urine. It's tartaric acid plus calcium acetate reacting with strontium peroxide. You use filter paper with a sample, moisten the tablet with water, and the reagent will wash onto the paper. So you put sample on the filter paper, then put the tablet on there, put water on there, and the paper will turn blue if there is hemoglobin present. It's not very sensitive. You have to have 200 red blood cells per high-powered field. And you can have false positives with bacteria or with bleach. The benzodine test is not used anymore because it was carcinogenic. Okay. So myoglobin, that is the heme protein of striated muscle tissue. It holds a reserve supply of oxygen and facilitates movement of oxygen in the muscle. That can show up in your urine if you have damage to cardiac or skeletal muscle, crush injuries, electric shock, myocardial infarction. The molecular weight is 17,000, so it's easily filtered through the glomerulus and excreted in the urine. So we do have a test that can differentiate hemoglobin versus myoglobin in the urine. Both are going to produce a positive test on your bloodstream. You can, this isn't the most accurate way, but if you have red plasma, so you draw a patient specimen, you spin it down. The plasma's red and the urine's red. That can mean hemoglobin, provided the sample wasn't drawn improperly, because you can also lyse the sample while you're drawing it. A clear plasma plus red urine can equal myoglobin, and you use an ammonium sulfate test to differentiate it. The ammonium sulfate procedure. You do this when your hemoglobin dipstick is positive, and you need to know, is there hemoglobin or is there myoglobin present? What we would do is we would have 2.8 grams of ammonium sulfate, and it's like a white crystal powder. And you put 5 cc's in it, and you let the, it's like in a little conical tube, and you let the urine filter down past the ammonium sulfate, and you collect it kind of in a jar below the ammonium sulfate. Then you're going to test that urine that filtered through the ammonium sulfate. If it's negative, or if it's negative, what is this? I'm sorry, I haven't been in there in 5 years. I always got this confused even when I was doing it too. Okay, if it's negative, if the dipstick is negative, that means there was hemoglobin present, because hemoglobin sticks to the ammonium sulfate. If your dipstick is still positive, even when the urine filters through the ammonium sulfate, if your dipstick is still positive, that means it's myoglobin, because myoglobin is soluble. Hemoglobin will stick to the ammonium sulfate. He put something in about hemosiderin. It is iron is stored when, it's a place where iron is stored. It's a pigment formed when hemoglobin breaks down. Sorry, it's a pigment formed when hemoglobin breaks down. And iron is stored when apoferritin is unavailable. It can cause dark yellow-brown granules in urine, and it's a marker of intravascular hemolysis. You can do something called the Prussian blue reaction to confirm it. And you would concentrate 15 milligrams or milliliters of urine, centrifuge it, take the supernatant off. You examine the sediment for yellow-brown granules. Then you resuspend that in 5 mils of 2% potassium ferrocyanide and 5 mils of 1% HCl. You let it stand for 10 minutes. Then you centrifuge and examine sediment for blue hemosiderin granules. pH is up next. So the kidneys regulate acid-base balance by excreting acids and alkalis. pH changes demonstrate and assess this function, and you have to evaluate it in a clinical context. There's no real abnormal range, and it doesn't remain constant for a long period of time. It's going to change from one urine sample to another and throughout the day. So the indicators, if you have an acidic urine, methyl red is going to change from red orange to yellow. And alkaline, it is going to be indicated from thymal blue, where it changes from yellow to blue. Incubation time is 60 seconds, and the pH range, it can detect anything from 5 to 8.5 in half units. So 5, 5.5, 6, 6.5. A confirmatory test is a pH meter with a glass electrode. So the dipstick urine pH is not as exact as a pH meter. You have to read it immediately to avoid a runover effect after dipping. So it's right next to the protein pad, and the acid buffer from the reagent, the protein pad can run over into the pH, and that can affect it because it's acid. So it can change your pH and make it falsely acidic. Runover from the protein falsely decrease pH, and if you have runover from the pad on the other side, which is the specific gravity, you can falsely increase the pH. It's inexpensive, quick, and you can perform it in conjunction with other tests. So significance of pH, persistent acidity. It can be acidifying drugs, dehydration, diabetes, diarrhea, fever, gout, high protein diets, and pulmonary emphysema. Persistent alkalinity, alkaline drugs. Some drugs that cause persistent alkalinity are Topamax, migraine drug, acute and chronic renal failure, diuretics, renal tubular acidosis, and urinary tract infections. If you have a persistently high pH, that is a really good indicator of certain bacteria that can cause UTIs. Protein. Small amounts of low molecular weight protein are filtered at the glomerulus. It prevents albumin, which has a high molecular weight of 69,000. After filtration, most of this protein is reabsorbed in the tubules. Less than 150 milligrams every 24 hours is excreted. TAM horsefall proteins, they are found in the ascending loop of Henle, and they are normal small with molecular weight mucoproteins secreted by renal tubules. They form the matrix of most urinary casts. So if we see protein in the urine, what's the significance? It can have physiological or pathological causes. Some of the physiological causes are exercise, emotional stress, exposure to extreme heat or cold, fever, pregnancy, or dehydration. Some of the pathological causes are glomerulonephritis, pyelonephritis, malignant hypertension, impaired tubular reabsorption, multiple myeloma, diabetic neuropathy, and preeclampsia. The most common indicator is tetrabromophenols blue. So it will change from yellow to blue. It detects primarily albumin. So if it is negative, it does not rule out other proteins. It just means there's no albumin present. A confirmatory test is sulfosalicylic acid test, which tests for any protein, including albumin. Now, I've never done that test. We do not do that here. The principle for the urine protein dipstick is the error of indicators. The color indicator will change in the presence of protein even though pH remains constant. It's a natural phenomenon, so normally indicators will change color in response to a specific pH. So in this phenomenon, the indicators change color in the presence of protein, even though the pH remains constant. And your sensitivity is 15 milligrams per deciliter. False positives are caused by highly buffered alkaline urine. So that can be medications or a really old urine. The longer it sits, the more alkaline it gets. Prolonged exposure, container cleaning compounds, benazopyridine. Once again, azo makes everything just orange. Plasma expander, PVP. Chlorhexidine gluconate, skin cleanser, and then bodily fluid contamination. So if you have mucus that gets in there or blood, they're going to cause a false positive. False negative, dilute urine, and amounts of proteins other than albumin. We want to correlate it with the specific gravity. A trace amount of protein in a dilute urine indicates a greater loss of protein than does a trace amount in concentrated urine. And that makes sense. If we have a very dilute urine, but we still have protein in it, that means you're losing a lot of protein. Versus if you have a very concentrated urine and we only see a little bit of protein. Microalbuminuria, that's the loss of albumin into the urine. It can be caused by diabetes mellitus, can lead to renal complications. In early renal disease, you lose about 30 to 300 milligrams a day. Progressing renal disease, it's over 500 milligrams a day. There's a recommended annual screening for diabetics. And those who do have microalbuminuria are monitored periodically. It's primarily excreted as a result of glomerular damage or disease. So additional tests you can do for protein are trifluoroacetic acid. Turbidity is observed when TCA is mixed with urine containing protein. It's not specific, so it detects any protein. You can do protein electrophoresis. That is very expensive. It's very specific and sensitive. So you will detect the number of protein, exactly what proteins there are. You've seen the electrophoresis before, right? In chemistry. Yeah, you can do it on urine. And you can do sulfosalicylic acid, where you precipitate protein by a strong acid and evaluate the turbidity. And these are all not really specific for a type of protein, but they will detect every protein, not just albumin. And the electrophoresis, I take that back. That is specific for proteins. It will tell you exactly what kind of proteins. But the TCA and the SSA, those are just general protein. Additional tests are the Kumasi blue dye. The principle is the protein error indicators. The dye binds to a variety of proteins, not just albumin. Color change of a pH stabilized dye from red to blue occurs when the protein binds to the dye. And you use Beer's law of intensity of the blue color to concentration of protein. So the more intense the blue color, the higher the concentration of protein. Very low sensitivity, 2.5 milligrams per deciliter. It's fast, you can automate it, and you need a small sample. Other types of proteins, you have Bence-Jones proteins. These are abnormal light chain proteins of low molecular weight, found in urine of about 50 to 80% of multiple myeloma patients. Coagulates at 56 degrees Celsius and redissolves at 100 degrees Celsius. Other proteins coagulate at 40 degrees but don't redissolve, so that is one way to tell the difference. Albumin is a heavy chain and it has a large molecular weight. Bence-Jones proteins are light chain and low molecular weight. we talked about this before, orthostatic proteinuria. Protein is excreted after patient has been in the vertical position for a long period of time because there's increased pressure on their renal vein. So all that protein and the pressure is causing it to be filtered in their urine, but when they lay horizontal, there's not the pressure. So that's why first void in the morning is going to be absent of protein. So you're going to void before bed, collect your first morning sample to test to make sure it's negative, and then you're going to collect another sample after they've been standing for a few hours. The first one should be negative for protein, and then the second one should be positive for protein. That's your confirmatory test for orthostatic proteinuria. We're in the homeward stretch, guys. We're almost done. Urobilinogen, formed from bili by bacterial enzymes in the intestines. Urobilinogen is colorless. It oxidizes to urobilin, which is brown. Most is lost in the feces, which gives the feces the brown color. 10 to 15% is reabsorbed into the bloodstream, which returns to the liver and is excreted into the intestines. Small amount is excreted in the kidneys. Normal level is 1 to 4 milligrams for 24 hours or less than 1 Ehrlich unit. I think we will talk about what the Ehrlich test is. So the significance, it's normally present in low amounts. It peaks between 2 to 4 p.m. We're assuming the patient has a normal wake cycle and they're not a night shift worker. Elevated in liver disease, intestinal obstruction, hemolytic anemia, and hemolysis. This is the test for it. It's the p-dimethylaminobenzoaldehyde plus urobilinogen, and the sensitivity is 0.2 milligrams per deciliter. Aldehyde or diazonium compounds react with urobilinogen to produce a pink to red color in an acid environment. What can cause false positives? P-aminosalicylic acid, sulfonamides, and p-aminobenzoic acid, which is a component of folic acid. Phenazopyridine, azo, once again, and porphobilinogen. And you can use the Watson-Schwartz test to differentiate those. You've learned about the Watson-Schwartz test from your porphyria? Yeah. Okay. What can cause false negatives? A true absence of urobilinogen if it's not detectable. Broad spectrum antibiotics, it alters bacterial enzyme flora in your intestines, so it can cause a false negative. Nitrites, formalin, or improper storage. We have nitrites next. Nitrates with the A, nitrates are normally present in the urine. Nitrites are a rapid and direct method for detection of significant and asymptomatic bacteria. So common UTI organisms are E. coli, Enterobacter, Citrobacter, Klebsiella, and Proteus. Those UTI organisms produce enzymes that reduce nitrates to nitrites. The reaction takes up to 4 hours, so the first morning urine is a preferred specimen. However, if your UTI is bad enough, it doesn't take 4 hours. Not every organism that causes a UTI is going to produce positive nitrites. Group B strep does not reduce nitrates to nitrites. So you can have a UTI with group B strep and your nitrites will be negative. But if your nitrites are positive, that's a confirmatory test that you definitely have a UTI. It's a screening method for bacteriuria. It's not to replace a urine culture. You still need the culture to find out what type it is, and so you can get a sensitivity to find out what antibiotics you need to treat it. If there are clinical symptoms, regular bacteriology tests should be performed, even if the nitrite test is negative. Because like I said, there are many bacteria that will still give you a UTI, but negative nitrate. It is the grease test. nitrite plus Kiehl arsenic acid to a diazonium compound. And then the second reaction is that plus the diazonium compound, and you will get a pink color if it's positive. And the sensitivity is 0.06 milligrams per deciliter. What can cause false positives? So it's a little controversial because urine should be sterile and have no bacteria. A specimen left at room temperature causing bacteria to multiply. I think any positive nitrite is positive. Even if it's been left at room temperature long enough, that means there was bacteria present in the sample. And to me, that means it's positive, especially if there are symptoms. For the test, I would say put this down as an answer, specimen left at room temperature, but in practice, if they're symptomatic, it shouldn't matter how long you leave it at room temperature. If they're symptomatic and they still have a positive nitrite, that's indicative of a UTI. But azo will, if they have symptoms of a UTI, they're probably using azo, and azo is going to make it positive because it's a red dye and it's going to stain it red, so you won't be able to tell. Very important, a negative result for nitrites should never be interpreted as an absence. The specimen might contain non-nitrate reducing pathogens. You may have had insufficient time in the bladder, low or no nitrate diet. An elevated urobilinogen level can cause false negative nitrites or absorbic acid. Leukocyte esterase. Leukocyte esterase is only produced by neutrophils. Very few neutrophils are seen in normal urine. An increased number of neutrophils usually indicates a UTI, and your appropriate screening for UTI will include pH, protein, and nitrite, because for UTI, your pH is probably going to be high. You could have increased protein, and your nitrite may be positive. You want to mix your specimen well and test fresh sample at room temperature. And this is the leukocyte esterase test reaction. And it can detect as low as 5 white blood cells per deciliter, or per high-powered field, sorry. What can cause false positives? Strong oxidizing agents, like we've talked about, bleach. Contamination by vaginal discharge. It's very common and normal to have neutrophils present in vaginal discharge. If formalin is used as a preservative, that can cause a false positive. Drugs containing imipenem, meropenem, or clavulanic acid, and those are all antibiotics. Nitrofurantoin, which is also an antibiotic, can cause your urine to be a brighter yellow to almost like slightly green color, and it may cause a misinterpretation of the color pad. False negative, a high specific gravity, and in a urine containing high glucose and protein. In that environment with a high specific gravity and in a urine that has glucose and protein, the white blood cells crenate and they cannot release their esterase, and that's why you might have a false negative. Other drugs that can cause false negatives are ascorbic acid, vitamin C, oxalic acid, cephalexin, which is an antibiotic, cephalothin, gentamicin, and tetracycline, and those are also antibiotics. So there's something called sterile pyuria. That is defined as the presence of white blood cells in the urine, but the absence of an infection. It's very common. Well, I don't want to say very common. You'll run into it more in an adult population. The most common cause is chlamydia, trachomatis, or Neisseria gonorrhea infection, because those are not considered a UTI. Those are STDs. So they can cause presence of white blood cells, but there's nothing really going on with the urinary tract. That's more of a genital issue. Other causes of sterile pyuria are HIV, diabetes, malignant hypertension, and something called interstitial cystitis. Interstitial cystitis is actually a very common disorder. 90% of the people who suffer from it are women. It is a non-specific bladder inflammation. You'll usually see it in older population. I think most people get diagnosed around the time they're 30. And these patients constantly feel like they have a UTI. So they'll constantly be coming in for urine cultures, and they'll be having positive white blood cells, no bacteria. And their urine cultures are always going to be negative. Their bladders are just constantly inflamed. No one knows why. One theory is it could be like an autoimmune disorder. It could also be like a disorder with their epithelial lining cells of their bladder. It can be kind of like leaky. But you will see sterile pyuria in people with interstitial cystitis, and it's a common thing to see in an adult population. Vitamin C, it's an ascorbic acid. That's a strong reducing substance, and the normal population does not take enough vitamin C to make this an issue. We're talking about people who have vitamin deficiencies. Like here, we have cystic fibrosis patients. They usually have issues absorbing nutrients in their GI system. So they're on IV nutrient supplements, taking tons of vitamin C. Patients like that are the ones that you would more see this in, because they're taking like massive quantities of this stuff. None of us would be taking nearly enough to cause this to happen. So too much ascorbic acid can cause a false positive clinical test. And remember, that's the confirmatory test for glucose and reducing substances in your urine. And it can cause false negative. So it can cause the false positive clinical test. It can cause the false negative glucose dipstick, false negative bilirubin, red cells, nitrite, and leukocytesterase. We're almost done. We got like 3 slides. Urine strip testing, you can run it on one of the readers. The principle is reflection photometry. So the intensity of reflected light is proportional to the amount of substance. It's very reproducible. Takes away the subjectivity. Unpreserved urine effects. So these are the effects of just putting urine in the fridge, in the container, and you don't put a preservative in it. The pH will increase, protein will increase, free hemoglobin will increase because your red cells will lyse and degrade. And nitrites will increase because the bacteria have more time to break down nitrates into nitrites. And what will decrease? Your bilirubin will decrease due to photooxidation and hydrolysis. Your glucose will decrease due to glycolysis, and if bacteria is present, they will metabolize it. Your ketones will also decrease if the container is not tight enough. This is goofy to me. Nitrites will go back into nitrogen. I would ask your teacher about this. I would ask her about that. And then your urobilinogen will be oxidated. So your microscopy results. Your crystals will increase because if your pH increases, you'll get more precipitation of like amorphous phosphates. And some of the crystals that we see like triple phosphates. Those are caused by alkaline urine. So you can see more of those precipitate. Bacteria will increase. And you'll see a decrease in casts, red blood cells, and white blood cells because they'll have time to sit and break down. That's it. All right, so what do you guys have for the rest of the day? Lab? Lecture. One more lecture, okay. All right, well,